Hello, I'm Jim McWilliam from White Plains, New York, and I'm going to talk about minimally invasive surgery on the foot with regards to Bunionette deformity. So you can see in this specimen, there is a varus alignment of the fifth toe. So the fifth toe is pointing medially. In Redfern's classification, a type 1 Bunionette would be a simple exostosis. A type 2 Bunionette would be a varus bow of the fifth toe. The difference being with a type 1 Redfern Bunionette, you'd simply do an exostectomy. In a type 2 Bunionette, you would do a metatarsal osteotomy. And we're going to demonstrate both types. When performing an exostosis, I like to make my incision just proximal to where the bump is. And you can see the bump here, and that correlates with the bump that we see on the x-ray. So I'm going to make an incision here. I'll elevate the soft tissue, and I'll use the burr to remove that bump. So we've marked our incision for the exostectomy. This is also a very reasonable incision if you're doing a distal osteotomy, which we'll demonstrate later. Make an incision. This is the bone's very subcutaneous here, so I'll typically make an incision right down to bone. This is a nice elevator to use because it's very sharp, has a great curve to elevate the periosteum in the area where you're doing your work, whether it's an exostectomy or an osteotomy. So I'm going to slip it into the incision, and simply by just lifting my hand, I'm able to elevate the periosteum in the area that I want to, dorsally, and if I choose to, plantarly as well. Here we're doing an exostectomy. I like to start the exostectomy with a pilot hole with a straight or cutting burr, and I can do that under fluoroscopy. That way I'll know that the more aggressive wedge burr for exostectomy isn't going to be taking off too much bone. So I'll check an x-ray here. Every time I run the burr, I want to make sure that the irrigation is running to decrease soft tissue injury and thermal necrosis. So I'll check that, and if you notice that it's not running, make me stop. So as you can see, I have a pilot track for my wedge burr, and the pilot track is the amount of exostectomy I will perform. The exostectomy will be done to the left of the metatarsal head. Now most of this is a rotational maneuver as opposed to a translational maneuver. Translational maneuvers generate heat, they don't cut effectively, and they tend to cause incarceration of the burr, and the burr can break. So you can see I'm rotating my hand in order to create that initial bony cut. Now I'll follow through with the exostectomy burr and just kind of travel along that same initial cut. And as you can see, I'm traveling along the same initial bone cut I did with the cutting burr, and we'll just follow it up and remove the exostosis. Now I do a couple things to know when I'm removing bone is the sound that you can hear of the burr, and then I'm feeling with my non-dominant hand, and then I'm looking directly at the specimen and with the fluoro. You can hear the bone cutting right there. We've done a complete exostectomy here, an adequate exostectomy. You can see my incision is a little bit dorsomedial, and that will allow you to avoid a lot of shoe pressure on the lateral aspect of the foot. After exostectomy with our wedge burr, I will irrigate all the bone debris out. You can either use the irrigation device that's integrated onto the burr. You can see I can go in there and irrigate out any extra bone. Or you could use a syringe. I'll typically use an 18 gauge blunt needle with a 30 cc syringe to remove any residual bone debris.